I'm Lieutenant Colonel Christina Rumayor. I'm the Deputy Chief of Behavioral Health for OTSG, and I have the distinct honor of serving as the moderator for this very esteemed panel of experts that you've got in front of you today. Many thanks to General Dingle, Command Sergeant Major Huff, General Brown, General Swan, and AUSA for inviting us to participate today. So this panel will focus on the methods that commanders and installation communities possess at their fingertips for assessing resilience, wellness, and behavioral health trends. So part of the benefit of going last of the panel is that you get to see everybody's discussions so far, and the con to that is that you've already gotten a lot of things that have brought up that people have stolen my thunder to speak to you about today. But I did want to I think it's excellent to be able to go last and kind of summarize, because the entire discussion today, I've picked up a few key themes that have already been discussed, as General Swan mentioned. General Brito started today and he said that the community effort is needed to move the needle. That was a direct quote from him, the first quote of the day. So General Stone said that restoring agility and resilience to the force is necessary. He also went on to mention that spirituality and faith is needed from leaders and our communities. So restoring the faith in the leaders in the communities to improve the wellness of the soldiers in the force. And Colonel Flaw kind of spoke to the 80% left of bang solution versus the 20% right of bang disease burden. And so when you look at behavioral health care, we as behavioral health providers are excellent at the disease piece of it. Right? I can diagnose illness and I can treat your PTSD and your mental illness. That's what I'm really great at. And the people to the right of me are excellent at the other 80% of the piece of this. The prevention piece, the wellness, the psychological resilience piece, that's where they excel in improving the health and the readiness of our force. So without further ado, I want to be able to welcome them. What we'll do is specifically, I'll introduce each of the panel, and they've got some specific questions to tell you a little bit more about their program, and then we'll open it up at the end for a little Q&A. So the prevention and the psychological wellness pieces are important community efforts requiring that community-based response. And this is a mind, body, and spirit response holistically to achieve that positive systemic social change across the force. So if you need any evidence of this, my guilty pleasure right now is watching Ted Lasso. And this is, Ted Lasso basically takes his team from zero to hero by just being that positive leadership, that emotional leader who's resilient and can bring up the people around him by just being a real good person. And I think if we can do that more, and I know that Dr. Quartana is going to speak to that specifically, that we can really make a huge bang improvement in getting the psychological wellness of our soldiers back on track from what we inherit historically by society already into the force. So without further ado, our first panelist is going to be Miss Erika Slayton. She is the Director of Military Community Service Programs for the Family Policy in the Office of the Secretary of Defense. And this is since November of 2021. Ms. Slayton is responsible for the leadership, management, and oversight of 3 centrally funded Department of Defense multi-million-dollar programs: Military OneSource, Military and Family Life Counseling, and Spouse Education and Career Opportunities Program. These programs together introduce a range of concerns that could detract from military and family readiness. So, Ms. Slayton, which services are provided by family members, by military and family life counselors, and what are the most common reasons that Army families seek military and family life counseling support?
Great, and thank you so much for the question, and I'm so happy to be a part of this panel. Lieutenant General Dingle, General Brown, General Swan, on behalf of the Deputy Assistant Secretary of Defense for Military, Community, and Family Policy, Ms. Patty Barron. She's no stranger to AUSA here. We're just, again, delighted to be a part of this panel. I just wanted to highlight one thing you said about community effort, and that's what this is all about. It's a community, and so we're happy to to be able to provide the military and family life counseling program as a part of the community to support our service members and families. So, it's so funny because the military and family life counseling program started back in 2004 as a pilot, and it actually started with 20 MFLACs supporting an Army unit in Europe. Okay, 20 military and family life counselors. And since then, we have grown to more than 2,600 counselors across the world. And specifically supporting the Army footprint, we have 900 counselors, over 500 of them, actually over 900 counselors, and then over 500 of them support children and youth. And so we're really delighted to be able to partner with the Army to provide these services that our service members and families need. So non-medical counseling, it's designed for those short-term, solution-focused issues that require that brief intervention. Improving relationships at home and work, communication, adjusting to a deployment, grief, loss. And we provide those services through our military and family life counselors and our child and youth behavioral counselors in a variety of settings, whether that's in a child development center, an Army community service, maybe it's embedded in military units. For example, we have some MFLACs that are in pediatric clinics and also embedded behavioral health clinics as well. So really great opportunities to embed those resources where our families and our service members are. Across the Army, when you look at the ways that child and youth counselors support our military community, the top reason that service members and families reach out to counselors for children is for general life skills. And that includes social skills and emotional management. Now, the top reason that service members and families reach out to those MFLACs that are supporting adults is for relationship issues. Boy, I've got relationship issues. We all got relationship issues, but that is the top reason. And it's mostly for communication issues. And so one of the ways that our military and family life counselors support around around relationship issues is through a brief intervention that we call our relationship checkup. So in the same way that you would go and you would get a tune-up for your car, or you would, let's say you've got to go to the dentist or to the doctor just to maybe you notice something, then you want to solve that at the very initial stage versus waiting. And so for for that brief relation checkup, that's an opportunity for couples to take a brief online assessment. And after answering those brief questions, have a few sessions with an MFLAC, and then they're able to take away some really amazing, tangible ways to strengthen their relationship, and then also identify areas for improvement. So that's one of the ways that they support specifically relationships. And we do have an overall a relationship campaign that's public facing. And what I love about it is that if you think about the Wizard of Oz, I know I love the Wizard of Oz back in the day, but the Wizard of Oz, the wizard's behind this curtain. What's he doing behind the curtain? And so that's when we thought about our relationship campaign, we really wanted to demystify what relationship counseling looks like. When a service member, a family member, or if they're having relationship issues, we wanted to make sure that they know exactly what to expect when they're speaking with a counselor. And so we love our relationship campaign. It's called Read the We, and it talks about what happens when you break up from a relationship, and how to cope with a relationship. We know that there are surveys that show that many service members die by suicide because of the termination of a relationship. And so we want to get at that, again, that 80% to make sure that our service members and families know the resources that are available to support them. And so overall, those are that's what MFLACs do in a nutshell. Short-term solution-focused counseling. We are there to provide support to the Army. So as they see needs, or our commanders and leaders see needs in the community, we're able to deploy those counselors and to support them when and where our families need them. Thank you.
Thank you very much, Ms. Slayton, for that excellent overview of the Military and Family Life Counseling Program and the wellness support that it can provide to our soldiers and families. Our second expert speaker is Ms. Latoya Johnson. She's a social science in the Chief of the Field Investigations and Evaluation section within the Behavioral and Social Health Outcomes Practice, BSHOP, at the U.S. Army Public Health Center, APHC. Ms. Johnson is a trained public health professional with a focus on community and health prevention and has a background in qualitative research, focus group facilitation, needs assessment, and program evaluation. Ms. Johnson is the chair of APHC's Diversity, Equity, Inclusion, and Accessibility Advisory Council. She's led numerous public health studies concerning BH Epicons, and the scope of BH Epicons include, but are not limited to, sexual violence, workplace violence, suicide, homicide, substance use, and social health indicators.
Thank you for that introduction, and thank you to AUSA for the opportunity to participate in this panel. Much appreciated. So I'm going to give a brief overview of our behavioral health epidemiological consultations, along with some additional resources that are available to leaders that may be or may have concerns with soldiers in their units exhibiting harmful behaviors. So one of those resources is the behavioral health Epicon, and what that is essentially is a holistic assessment of a unit of concern. About half of our Epicon requests are due to a perceived increase in suicides or suicidal behavior. However, we do Epicons concerning any behavioral health issue or social health issue. We've been doing Epicons for about a decade now at this point, a little over a decade. And some of the most, earlier this year, we put out a report called A Decade of Behavioral Health Epicons, Lessons Learned. And so what this report did was summarize 30 Epicons, and the report summarized the most salient findings and recommendations that we've seen over the past decade. And this is a resource available to leaders if they're seeing similar trends in their units. So over the course of the years, our Epicons have typically fallen, well, the issues with our Epicons or that we've seen have typically fallen into three categories: the behavioral health, the social health, and the organizational environment. Some of the most consistent findings we've seen are communication challenges up and down the chain across all echelons. There have been issues with housing, the barracks, the living conditions, social support, resilience, sleep problems. Actually, half of the soldiers that died by suicide for this report had documented sleep problems. And so those are some of the issues that we've highlighted in that report. We've also summarized some of the most common recommendations that we've provided to stakeholders. So things like high op tempo that has come up in nearly every Epicon with the unpredictable training or the unpredictable schedules, the trainings. So we encourage leaders to adhere to the standard duty day, to try to decrease some of the stressors associated with the op tempo. We encourage leaders to utilize the CR2C to help implement recommendations and develop behavioral health campaign messaging and things of that nature. We also have developed a behavioral health Epicon self-assessment tool for leaders to utilize. And this is really a precursor to the Epicon. So the tool is currently in its pilots, it's in a pilot phase. It's been utilized at some installations, and we've been getting good feedback, and we're very receptive to improving the tool. But currently it's in a Excel format, and it covers the three domains: the social health, behavioral health, and organizational environment. And what we would like leaders to do is use this tool to do an internal assessment and identify any gaps in resources or any other issues that may warrant further investigation, and try to address those issues internally before requesting external assistance. But if external assistance is still needed, we are definitely available for an Epicon, and it would be more tailored and definitely informed by the Epicon self-assessment tool. So that's a resource. Some of the impacts that we've seen from our Epicons. I know one year we did an Epicon at Fort Carson, and those results were part of the impetus behind the development of the embedded behavioral health program, which we continue to evaluate today. Most recently, we completed an Epicon at Fort Wainwright, and that led to a series of improvements for the installation, but that namely led to the development of the G9 Quality of Life Initiative. And I'll stop there. I'll end there.
Short of a behavioral health Epicon, are there resources that are available to commanders to assess their formations and climate and risk if there is a perceived spike?
Yes, so the Epicon self-assessment tool is a really good resource for that. We can provide a request for information to give you a quick snapshot of your unit and maybe point you in a direction to where you could focus some of your attention or resources on.
Thank you very much, Ms. Johnson, for those valuable lessons learned over the 10 years of BH Epicons. So our next key speaker is Dr. Quartana. He is the Assistant Director of Research at the Center for Military Psychiatry and Neuroscience at Walter Reed Army Institute of Research. Dr. Quartana received his Ph.D. in clinical psychology from the Rosalind Franklin University of Medicine and Science in 2008, which was followed by a clinical psychology residency in the Department of Psychiatry at the University of Illinois, Chicago, and a 2-year NIH-funded fellowship at Johns Hopkins University School of Medicine. During his tenure at Rare, he has been an investigator on numerous projects ranging from tightly controlled laboratory investigations of sleep deprivation, affect, and human impact of the People's First initiatives on soldiers' health and readiness outcomes. He's the lead investigator of the Behavioral Health Advisory Team, the competency area manager for Military Operational Medicine Research Program's Far Forward Behavioral Health Program, and the co-chair of the JPC5 Early Assessment and Interventional Strategies for Service Family Members and Strategies for Service Member and Family Psychological Health Working Group. That was a mouthful. I apologize. Dr. Quartana, what does the data show regarding the impact of the domain-specific behavioral health leadership on the health and readiness of soldiers?
Thanks for the introduction. And yeah, we got to work on shortening up those titles there. It's a mouthful. We use acronyms, but no one would know what they mean. But I appreciate the opportunity to be here to talk about behavioral health broadly, but I'm going to sort of focus in on a specific area of research that we've been engaged in for the last about 10 years, honestly. So early on, and even still today, a lot of folks talk about transformational leadership. The problem with transformational leadership, like Ted Lasso, he's clearly a transformational leader, but what does it mean exactly? How do you measure it? And as a scientist, it's critical that we're able to operationally define constructs that we measure. And we've really had difficulty measuring transformational leadership or general leadership, like my leader's good, my leader's bad. That's there. And then there's like the reason is why. So we developed this notion and borrowed from the organizational literature. I don't want to say that we came up with the idea, of course, but we borrowed the idea of what's called domain-specific leadership. And we've really focused in on behavioral health specifically. And we've engaged in this work in a number of different areas of focus. And I just want to maybe briefly talk about a couple. One's already been mentioned as a risk factor for suicide, and it's a risk factor for really all mental health issues. It's a cross-cutting problem, and that is sleep deprivation and sleep loss. It is ubiquitous in the military because it's a necessary function of completing the mission, period. And so the idea of, we're going to give everyone 8 hours of sleep is just probably not realistic, and particularly far forward and downrange. But there are things that leaders can do to facilitate their soldiers sleep, right? You can provide opportunities for downtime. You can encourage napping. You can sort of encourage soldiers not to, at the end of the day, sit down and play video games until 3 a.m. when they have to get up and train at 5 a.m. or 6 a.m. or whatever it might be. And those don't sound like very fancy solutions, do they? They're not, but they're highly effective. And in terms of the sleep leadership piece, we've actually shown, and we've shown this in soldiers. We're showing it on ships with sailors. If soldiers have a perception that their leaders actually really just care about the sleep, about their sleep health, and provide these simple opportunities for naps or maximizing sleep, providing appropriate sleep quarters when available, of course, it has a substantial impact, not only on sleep, but again, as a cross-cutting function. It has reductions in suicidal ideation. It has reduction in depressive symptoms. It has reduction in anxiety. And of course, all those things feed into these harmful behaviors that we talk about: alcohol use as a coping mechanism, suicide attempts and completions, family problems. We talk about the MFLEX, who play a critical role there. So that's one example. And it's important to note that when we study this, we ask people about specific behaviors, not just, is this good or bad? And we're showing an effect of these domain-specific concepts, and sleep is one, above and beyond the concept of transformational or just general leadership. These effects also bleed over into perceptions of unit readiness. So we do believe that they're probably going to have a critical impact on actual performance and basically sustaining the mission, sustaining lethality and force readiness. Most recently, COVID, we looked at COVID and we looked at leadership in the context of whether soldiers are adhering to the recommended public health practices to stop the spread. And most recently, vaccinations. Of course, there's a mandate now, but before that was out, we were studying, well, what role does a leader play? And we found, just simply asking soldiers, if your immediate supervisors are encouraging you to get a vaccine, are you more likely to do it above and beyond a number of other factors, your attitudes about the safety or the importance, like whether you frankly even believe it is safe or important for you or your family or your unit members, and these general leadership concepts. And just asking that one simple question as it pertains to vaccines, it was associated with a substantial increased likelihood that a soldier would be vaccinated, or if they were not vaccinated, they were more likely to say that they'd be willing or would intend to get vaccinated at some point. So it's just some examples that you talk about Ted Lasso. So Ted Lasso, and you said it well, like he just basically meets the needs of people where they are. And it's just through simple things. And it has just a massive impact. So one thing we've done with these constructs when we've assessed them is we don't just stop with saying, hey, look, we found this, neat statistical effect. We produce, and they're available at the RARES website. We produce sort of, we call them quick guides, but they're guides that we provide back to units and they distribute down to different echelons of leadership. And we do have some studies with respect to the sleep piece when we do give those to folks and they distribute them down to line level leadership, that you start to see improvements at the unit level broadly in terms of the sleep behaviors and other behavioral health outcomes. So I'll stop there, but that's where we've been heading with respect to this literature. And there's a lot more to do, but yeah. No, there's more. Sure.
Sir, can you kind of speak to the operationally important research as it applies to leadership that's currently underway and speak to some of the key takeaways from the analysis?
Yeah, and so apart from just, as a leader, do they engage in these specific behaviors around the needs of a particular unit? We've started to really dig into, and this has been an effort with 3 Corps as part of the whole People First initiatives that they're running there. And we've been helping with that evaluation, actually in partnership with Army Public Health. It just made sense with the focus on reduction of harmful behaviors basically empowering soldiers to feel comfortable stepping in when they see things like alcohol misuse or bullying or potential mental health issues or sexual assault or harassment or extremism, disinformation, all these big concepts that are sort of a big deal. They're a problem right now and they're a priority to sort of plug that hole, if you will. So we've really started looking at trust. And this wasn't our idea. It was 3Corps' idea, right? And the idea that if we can enhance trust between frontline supervisors and their subordinates, that all of these things are going to improve. Again, it's all about cross-cutting, bang for the buck, right? And we do have some really strong data across a couple of time points now to suggest that the more that soldiers trust in their immediate supervisors, the more likely they're to report these problems, the more likely they are to be satisfied with the outcomes of, for instance, if you report sexual harassment and an investigation and something is done, they're more likely to be satisfied. And these effects are above and beyond even those leadership components we were talking about, which suggests that you could be a great leader, but if you don't have trust in your leadership, both locally, but also more broadly, right? Do you trust your battalion leadership? Do you trust the brigade? Do you trust the Army in general? These all have an additive effect. So right now we're trying to boost trust. And one thing that we've worked with them to develop is this concept of what they're calling like golden triangle calls. Okay. And this is asking all supervisors to make a call, to have a touch point with a close family or relative of their subordinates, to just say, give them an update, what's going on, maybe brag about them, talk about something good, or if there's maybe something going on, try to just have that discussion. It's really to bridge that gap between the Army family and your sort of, family outside of the Army. And that has seemed to, from the soldier perspective, when they know those calls have been made, they're much more likely to have trust in the leadership. And they also feel that everything they're doing is going to make them more ready to go to war. We specifically asked that question, among others. So those are some new areas we're moving, and we want to understand how trust and some of these domain-specific leadership behaviors sort of work together. That's it.
Thank you very much, Dr. Quartana, for that very impressive research overview about leadership and its impact on the force and the wellness of soldiers and their readiness. So our final expert panelist, and then we'll try to get to some of these questions, is Chaplain Lieutenant Colonel Grace Hollis from the Office of the Surgeon General. Chaplain Hollis entered the chaplaincy with the Army in 1988, serving soldiers, family members, and DoD civilians while stationed at Fort Hood and Fort Bliss, Texas, Mannheim, Stuttgart, Germany, Afghanistan, Fort Meade, Maryland, and Arlington National Cemetery, where she served as the Deputy Command Chaplain, Memorial Affairs. Additionally, Chaplain Hollis served as the Strategic Staff Officer in standing up the Chaplain Recruiting Directorate, Office of the Chief of Chaplains. She continues to humbly serve God and country as the MEDCOM Forward Operations Chaplain, Office of the Surgeon General, where she is committed to nurturing the living, caring for the wounded, and honoring the dead. Chaplain Hollis, how does the chaplaincy interface with command, community, and behavioral health resources to provide support for those struggling with life or emotional stress?
Thank you. And I came in 1998. Lord help me. That's all right, sweetheart. I'm a chaplain. Thank you so much for this opportunity to speak to you all, this brilliant audience, and General Dingle for entrusting in me that I will do a great job. And thank you for that questions, because chaplains interface with the command at every echelon as a staff officer and advisor to the commander in all matters pertaining to religion and spirituality within the ranks. Through pastoral care and counseling, ministry of presence, staff work, attending command functions, chaplains are able to keep their pulse, their finger on the pulse of the unit in order to fully integrate and develop religious support plans and programs that best meet the priorities of the commander, meet the needs of the unit, and most importantly, care for the soul of the Army by providing help or hope or healing to those who may be struggling with life issues and emotional stressors. That's how the chaplain interfaces with the command as far as the community is concerned. Chaplains on a daily basis are moving throughout the unit, always assessing the emotional readiness and resiliency of the unit by conducting weekly worship services, which you all are welcome to. Weekly worship services, conducting a ministry of presence, conducting morning devotionals, conducting Bible studies, resiliency, readiness groups, support groups. We are assigned in behavioral health inpatient clinics where we teach classes and participate in group discussions. So chaplains are everywhere. And so it's important that we support the community by participating in the areas that where we are going out and doing our ministry of presence. As far as behavioral health, I will be very transparent. Had it not been behavioral health and my spirituality as a chaplain, I don't think I would be here today. So it is important that we all take care of our soldiers. As far as behavioral health is concerned, through the effort of the chief of chaplain, who developed a spirituality readiness initiative, SRI, chaplains and behavioral health clinicians are coming together. We are training together. We are beginning to collaborate more intentionally to support our soldiers and those vulnerable populations. And when it comes to combating suicide and combating substance abuse and combating negative outcomes or behaviors, it's very important that we emphasize or stress the spirituality aspect of the H2F. Holistic and health fitness, because when we dismiss that spirituality is a primary means as a way to support and ensure that our soldier, family, and DOD well-being, it does leave many to suffer spiritually in distress. For people in our ranks, they are in need of our help. I get a little emotional because I truly want to help. And people in our ranks need help in dealing with combating suicide, in dealing with suicidal ideations, in dealing with substance abuse, in dealing with negative behaviors and the outcomes, in dealing with death, life and death issues. And so I am grateful that in the FM 7-22, holistic and health fitness, it now emphasizes spirituality as important in the readiness of the unit. So those are just some ways in which the chaplain interfaces within the community, the command, and behavioral health.
Thank you very much, Chaplain Hollis, for that insightful look into the collaborative ways that chaplaincy can support our unit wellness and the Spiritual Readiness Initiative. So this is a question for the entire panel. Are there any examples of successful unit or installation-specific programs that leaders could consider implementing at their respective locations to improve psychological wellness and resilience?
I'd like to answer that so I can get mine out. Amen. Well, a couple of things that the chaplaincy are doing is the Strong Bonds events. Actually, that is under transformation right now. And soon it will include reach out to Army spouses. Chaplains are implementing a Duty Day with God to incorporate the SRI, the spirituality, resilient or readiness initiative. Chaplains are doing newsletters. Chaplains are doing duty days and resiliency days and just events to incorporate the spirituality readiness initiative. Also doing newcomers briefs. The SRI brought together 13, command teams, Army command teams. It brought together drill sergeants. It brought together UMTs. It brought together behavioral health clinicians, and the chief of chaplain socialized the event in 13 locations. So it's well known out there, and chaplains are already implementing a lot of the programs. Thank you.
And I'd add to that. First of all, thank you for what you do. And I know from our data, the chaplaincy plays a huge role in behavioral health, and a lot of soldiers feel much more comfortable speaking to a chaplain than they do going to a trained behavioral health professional and a sort of at an MTF as an example. A couple of things that have seemed to be effective. One I already mentioned was this concept of golden triangle calls to strengthen the bond between immediate supervisors and soldiers. And again, those materials are available, and there's other examples of specific guides we provide that have been effective at the RARE website. There's a program called Victory Wellness. And really just fundamentally, that is just upstream quick litmus tests or checks with soldiers. It's just how you doing? And soldiers like it. There's always the concern about impact of, hey, if someone finds out I have a mental health problem, it's going to affect my career. It's going to be a negative thing. But it turns out that the majority of soldiers like this program, and the MFLEX actually have a big role in that. They do a lot of the checks. And I know that's particularly effective because we want to get as far left of the problem as we can. The earlier we can identify an issue, the more likely we are to prevent it. Same with the calls, right? A lot of times these calls, just anecdotally and talking to leadership, they identify that there is a problem and there may be a risk associated with a given soldier, and you can get out in front of it that way. And then same with the Victory Wellness, of course. But yeah, it's really about utilizing all the resources available. Behavioral health clinics are, as I'm sure many of you know, running at well over 100% capacity right now. We can't get enough behavioral health resources to support the needs of soldiers. So we got to be creative and find ways to really stop problems before they start, because it often is just too late. And I'm not even talking about a suicide event. I'm talking about just people struggling. So the further left of that we can get, the better off we're going to be.
And if I could, I'll just offer one other program that seeks to encourage help seeking among service members and families, and it's called REACH. Resources Exist, Asking Can Help. It's for service members. There's also a model for spouses as well. It is really about this mindset about putting on your own oxygen mask before you're able to help someone else. And so it is a facilitated discussion among peers. They talk about these barriers to care, whether it's perception of being broken, whether it's related to loss of a security clearance, whether it's not knowing what resources are confidential, just not knowing what resources are available. So it's been implemented at a few installations, and I know particularly at Fort Leonard Wood and also at Fort Huachuca, they have implemented it successfully. And what I love about it is that it brings in not only resources at the local level, but it culminates in a call to military one source. So the group then decides what is the issue that we're going to call military one source about. They decide, it's like, I'm having stress at home or at work, and then the consultant who answers the phone is able to offer some supportive resources. It's been very impactful, eye-opening, and service members are more willing to reach out for help, not only through military one source, but again, those local resources as well. So that's been really successful.
Thank you for that. So we have way too many questions. I think I need another about half an hour for us to get to all your questions. So I'm thankful very much for them because it's clear that you're very interested in what we have to say. But I'm going to try to summarize some of them into one or two questions. And this one is for pretty much anyone on the panel. And it's how are we engaging leaders and training them to support soldiers and families that need behavioral health resources without fear of retribution or being looked down upon, stigma. And another piece of that is talking about how do we empower our junior leaders to take action and utilize our services. And I can speak to a piece of that that recently just happened while the panel collects their thoughts is there was just this past week a G1 Xord that just completed being published. And it is a chain teach for suicide prevention that is now occurring, again, at the senior leader level from the top. It is a chain teach of the leaders directly down to their first line subordinates who will then teach down the line to the lowest level soldier about risk behaviors, primary prevention efforts, utilizing the different levels of services, trying to do the leader-led focused actions to destigmatize treatment, outreach, resiliency, and really getting to know one another's soldiers that they have in their formations. And so that is kind of our newest thing that we're doing to try to get at that.
Yeah, I think that's an extremely complicated question. And I think I think fundamentally it's just going to be a culture change. And it's going to be sort of like a Kuhnian paradigm shift. It's slow going, but when it happens, you'll know. And I actually think we're seeing it to some degree because we are seeing reductions in sort of people feeling stigma about mental health issues. It's still a significant problem. About half of soldiers who have a problem feel some sort of stigma or that they may face retribution, but it's less than it used to be. And I think ultimately it's going to boil down to, people get the help they need and just see that it doesn't end a career or lead to retribution. I just think it's going to take time and it's going to take actions like that to sort of engender that trust and culture shift.
I've already talked about one of the ways through the REACH program, which again, I think there's nothing like having that facilitated discussion, that small group to get together and to talk about, again, those barriers to care and just make it a very open forum to discuss it. One of the ways that I've seen just the value and more of this communication talking about it is the fact that we have been able to give briefings at within professional military education. And that's been really a very much an opportunity to talk about our resources and to do more of a deep dive on them. And then also play a recording of what it's like to call Military One Source for, as an example. And so whether you're looking for non-medical counseling or financial counseling or peer support or elder care, what does that look like? And so being able to really explain exactly what service members and families can expect from these resources, I think goes a long way at helping people not only understand it, but then also reach out to the resources when they need it.
And unfortunately, for me anyway, that is our time. So on behalf of the Army Surgeon General's Office, I'd like to graciously thank all of our fantastic, very, very well-versed speakers for providing their extensive subject matter knowledge to this panel today. The information that you provided clearly will help leaders and the force going forward in improving life for soldiers and their families. In closing, I'd like to thank AUSA for their continued support to Army, the soldiers, and the families that support our soldiers. Lieutenant General Dingle and Command Sergeant Major, I will open the floor to you for your closing remarks.